back. And the next session is the importance of evidence in digital health and pitfalls to avoid. And as you heard a number of times in the last session, there was questions about the importance of evidence and the type of evidence. So a quick introduction to Joe Kvedar. He's a professor of dermatology at Harvard Medical School, immediate past chair of the board of the American Telemedicine Association, and editor-in-chief of NPJ Digital Medicine. He's an author of 2 books on digital health, both of which I can commend: The Internet of Healthy Things and The New Mobile Age, How Technology Will Extend the Health Span and Optimize the Lifespan. I first met Joe in Boston about, I think, 15 years ago at the Partner Connected Health Symposium, which he ran. It was outstanding and became an annual pilgrimage for me for the latest digital health innovation in products, services, and policies. He is a physician, scientist, and teacher, and thought leader, and the Digital Health Society is honored to have him present today. During the pandemic, and whilst I was advising Guy's at St. Thomas's Hospital, the hospital was approached by many companies and academics to support research into vaccines and tests for COVID. This was my first real exposure to the world of science papers and publications, and the importance and influence of some of these publications. It was a mysterious world. Also, hospitals always ask startups what evidence they have to show their product or services works. Then earlier this year, again in Boston, Joe and I met at the ATA Annual Summit, and we got talking about his new role with Nature, the prestigious scientific journal. This led to today's presentation. Whether you are a researcher, an innovator involved in healthcare management or policy development, digital health entrepreneur or investor, I am sure we will learn a lot. The importance of the role of evidence in the development of healthcare cannot be underestimated. Joe, over to you.
Thank you, Bledden, for such a warm introduction, and thank you for inviting me. I'm doing a sound check now. You can hear me? And the slide, can you see the one slide, or you see the whole
Yes, I can see the slide.
All right, great. Thank you. Thanks for that. Well, again, I thank you very much for this opportunity. As you can see here, I wear a number of hats. Today, I'm going to focus on my role as an editor. And my hope is to speak mostly to the non-scientists in the audience, although, of course, I know there are people who do research for a living on the in the meeting, and hopefully you all will get something out of this as well. But it's primarily for the entrepreneurs, the business people, the policymakers, to understand some of the tension that goes on, as there's really 2 different movements afoot. One is the movement of innovations in the marketplace, and the other is how evidence happens and how it gets published and how it gets vetted and so forth. So that really is it's that tension that we're going to keep coming back to over and over and over again for the next few minutes. And we'll have plenty of time for questions. I know there's an opportunity for you to put questions in many different ways, and Bledden has been kind enough to offer to moderate that towards the end of the talk. So I expect that there will be at least as much dialogue as me pontificating here in front of you. But I wanted to start out by just saying a word or two about the journal itself. It is, as Bledden indicated, a portfolio journal, Nature being perhaps the top journal maybe in science in the world. Some could argue whether it's the top 1 or 2, but it's among the top 1 or 2 for sure. And like many other high-profile journals, one of the strategies that the journal has used for growing its footprint has been to have sub-types of journals. So you have Nature, Machine Intelligence, Nature Medicine, and ours is the digital medicine vertical for the Nature portfolio, and it's called NPJ. That stands for Nature Partner Journal, so you can kind of forget that. The NPJ Digital Medicine Most people will call us Nature Digital Medicine. We respond to that too when people refer to us that way. It is an open access journal. That means that you can go to the website, and I hope you do. NPJ Digital Medicine is the website. I hope you go and look at the papers because they're all open access. Anyone can download any paper. If you choose to submit a paper to us, and it gets accepted, you'll be asked to pay for that on the front end. It's called a manuscript processing fee. And that's, again, that's a business model that a number of journals are using these days. That's our model. I rather like it. Also, we don't have a paper journal. It's purely an electronic publication that allows us to publish papers when they come out. Once we accept them and they go through a final QA stage, they come out on the website. A little bit like when you go to those small plates restaurants and they bring the food out when it's ready. And I like that very much too. So I'm quite keen that I took over the role of editor-in-chief in 2020. My predecessors, Eric Topol and Steve Stein, who will launch the journal in 2017, I want to say, or 2018, and did a fine job. And it's just grown like a weed. I'm so pleased to see how many manuscript submissions we get and the interest in the journal. And so we'll weave back and forth a little bit on that. Everything that comes out in our journal is peer reviewed. If that's not a familiar concept to you, I'll explain it here briefly. That is that if you submit a manuscript, one of either myself, one of my deputy editors, or more likely one of our associate editors will look at it. And if we think it's of interest to us, invite people who we can perceive of as your peers in the industry. It's a blinded process. You don't know them. You can suggest people. We may or may not use your suggestions of reviewers. And they then comment on the manuscript suitability for publication, what they see maybe as potential scientific flaws, things you might have missed, ways you could communicate better. We wrap that up, send it back to you, usually for a revision, almost always. And then if you're able to respond to those, the paper will get published. That's roughly how it goes. Papers can get rejected in the beginning if we don't think it's suitable. They can get rejected after review sometimes if the reviewers think the science is flawed. And we're mainly, I'm going to finish off the kind of talk about the journal part, so to avoid this feeling to you like an advertisement. But we're mainly looking for I use four broad criteria when I look at manuscripts. The first is it digital medicine? Now, these days, there are a lot of digital medicine tools out there, things from artificial intelligence algorithms to ways to provide digital clinical trials in silico to wearables. You know many of them yourself. Those particular tools, having been out there and having been studied, are stable, and they are ways, for instance, if you decided you wanted to use Fitbit to show something about, I don't know, respiratory disease. Well, we wouldn't probably take that paper because the Fitbit itself is not particularly an innovation anymore. And you're really more talking about a paper that goes in a respiratory journal. So is it digital medicine? Number two, is the science sound? That's really important. And by the way, these four, there's no particular order here. I talk about them all the time and I mix the order up routinely, but it has to be sound science. The methodology has to be sound, et cetera. Is it clinically relevant? It's a journal that we want clinicians to embrace. There are plenty of places for people to put basic science and engineering, such as IEEE, basic science and informatics, such as JAMIA, et cetera. We want this to be something that a clinician could look at and see how it might apply to their life should it become commercializable or in the future. And the last one is it novel? Arguably, this may be the most subjective, but if there's something in the literature or more than one paper that sort of shows the same thing and you're doing a little bit of a twist on it, we probably will recommend you send that elsewhere. So those are the four criteria that we use. a very long-winded introduction on this, on the title slide, I know, but that's the journal. One last thing I'll say is one of the things that I've done, and this I hope will be of interest to the non-scientist in the audience, but one of the things that I've done is once a month, I work with a group of medical students that have volunteered to help, and we publish one editorial. I use the term plain old English because so much of the science is arcane and difficult to understand if you're not trained in that discipline. We try to boil it down in less than 1,000 words and say, why is this paper impactful? Why should you care? Why should you notice if you're not a hardcore scientist? So if you want to look at some of those, the easy thing to do is to go to the website, NPJ Digital Medicine. There's a search function. Make sure you choose this journal as opposed to all nature journals, and just plop in my last name, Kvedar, and they'll come up. And they may be fun for you to look at. And again, we do about one of those a month. So that's the journal. Again, long-winded, but I'm glad you were able to stay with me. And now we're going to talk really about why evidence is important. Somehow I'm having trouble. There we go. So there's, as I said earlier, a fundamental challenge in the marketplace. Founders, entrepreneurs, business people want to move fast. There may be many reasons for this. They may perceive competition. Often they're funded by venture capital dollars. Those dollars need to turn over every 10 years for the venture folks to raise another fund. So they have pressure. They want to turn companies into something that has a lot of value and gets an exit in a few years. So that's the pressure that founders often feel. Contrast that to the world of science, which is very deliberative, very thoughtful. The goal in science is to not make a mistake if you can. That is to say, we don't want to publish something that turns out later to be wrong. Of course, that's happened over history. There are many examples of it. But we try very hard, and that's why we have the peer review process and others. And that means that science sometimes lags and feels for founders and entrepreneurs rather slow compared to that market pace they want to move at. So that really can lead to founders choosing strategically to cut corners for those pressures. Maybe that's not a bad thing. Maybe science is too deliberative and slow. Maybe you should be moving at the pace of the market. But I'd caution you on that, and I'd offer a couple of thoughts on that. The first is that most of our digital health innovations involve efforts to improve patient well-being, i.e., lives are at stake. We don't really want to put stuff in the market that might be harmful. Now, again, you can argue that something like an activity tracker or step counter does not need that level of scrutiny. Sure. But if you're talking about, let's say, using a watch app to check atrial fibrillation or check a heart rhythm, I would argue that needs a little bit more scrutiny, because you could, A, mess up someone's perception of their heart rhythm, or God forbid you miss something and they get sick and they should have been picked up. So it is serious business. And then if you don't buy that, I think, and you're selling into the marketplace, anytime a clinician hits your solution, they're going to start asking questions about validation, about evidence. It's just how we think and how we're trained. It's the only way we know of to sort of separate the wheat from the chaff. So if you don't buy that your innovation is particularly relevant to saving lives, you're probably going to end up, if you're selling into healthcare, dealing with a chief medical officer at some point. Usually that person has some public health training, and they're going to scrutinize your science. So those are a couple of reasons why you might want to think a little bit hard about cutting corners. So why can't common sense guide us? After all, let's say I have an innovation, I put it into the hands of 20 patients, and they all get better. All 20 get better. You think, well, this becomes obvious, right? It's obvious. Why do I need to do some long-winded, slow clinical trial to prove something that's obvious and common sense? Well, there are a couple of reasons I would, again, urge against that. And I'm going to give you a couple of real-world examples in a minute that would help me, I think, with that caution. The first is cognitive bias. I think we're all aware that there are many. The field of behavioral economics has penetrated, right? We all know about these things, confirmation bias, et cetera. The one I like to, just because I think everyone is familiar with the placebo effect, but if I take 100 people, split them into two groups of 50, of the 50, I give them a real, let's say, cholesterol drug, and the other 50 get something that looks just like it, but it's a fake pill. Some of those people that get the fake pill will get better. Their cholesterol will get better. Why is that? Well, because of the power of suggestion, because mind over matter, because of a lot of things. And those are all cognitive bias things. So those things influence our thinking. They influence the way we look at things. And again, if you don't buy that, I know you all know, those of you who are founders, entrepreneurs, trying to, again, move something through the market, create value, and then exit, you have a conflict of interest. You're too tied emotionally to the success of your innovation. So you really can't just use common sense, in my opinion, as a goalpost. Let's talk about a couple of examples that I think are fun from history, just to illustrate this point. So the first is this concept of the dog days. I think most of you probably know where that phrase comes from. But the Romans saw that the dog star, Sirius, burns brighter, roughly from early July to early August. And so they coined the term dog days of summer because they thought that the brighter burning star gave off heat that warmed the earth and made it hotter during that time of year. Well, again, there's a correlation there. Yes, the star is brighter, but of course, it's our own sun that's providing that heat, and we know that now, and it seems kind of quaint, but we still use the term dog days. That's an example of causation and correlation being in conflict. Another one, and I had the privilege recently of going on a trip to Tanzania and seeing some of this in action. This is the yellow acacia tree from Tanzania. And it turns out that the first white people that came to that country decided that this tree was somehow related to fever. Now, malaria was the disease they were getting. They didn't even know what malaria was at the time, but people got sick when they hung around these yellow trees. So they called them fever trees, thinking that something about the tree was responsible for the illness, when in fact, the yellow acacia grows more closely to bodies of water, which are breeding grounds for mosquitoes, which are in turn the carriers of the parasite that causes malaria. And so we now know that it doesn't have anything to do with the tree itself. Again, causation and correlation not linked. So I just share those two kind of fun examples with you. And there are many. And once again, if you simply look at a small sample of people who get your innovation and they have a difference in their health, you could be making this kind of false judgment. That's why we need more evidence as we look through these things. So let's talk a little bit about science and the scientific process. The goal of science is to isolate one variable and follow it over time to draw conclusions on its effect. Now that is our North Star when we're doing science. It's easiest in the biochemical or the molecular biology lab to do that sort of thing because it's a highly controlled environment. You can be very careful, etc. Of course, the conclusions that we draw from those experiments are a long ways away from usually reality of what's going on in human beings. They're a start, and of course they lead to discoveries of all sorts. Nowadays, we're in the middle of the Nobel Prize season, and every day you hear about a new Nobel Prize. Almost all of them originated in the lab in this way. So I'm not knocking that kind of research at all, just pointing out that it's easier to do very fine control in the lab, much harder when you're talking about real world and clinical studies on patients. And I'm going to talk a bit more about that in a moment. But the idea is, can we isolate one variable and study it compared to an exact copy of whatever sample you're using, and that doesn't see that variable. And does the variable then make a difference? Even then, you're just saying that variable correlates with, and it's hard to do causation research in clinical studies. So once again, but we often will call that pretty good evidence if you can do it that way. So let's talk about ways to gather evidence. This is a very quick run through some study design paradigms that you might find useful if you're on the other end of either thinking about how you want to prove out an innovation, how you want to validate an innovation, or how you want to evaluate someone who brings you an innovation. So the first two really, observational and before and after, are fairly similar. Observational studies are what I've been referring to so far during the talk, which is take a sample of individuals, apply an intervention to them, and observe them. That is the weakest form of evidence possible for the reasons that I've mentioned. But the main ones are here. There's a concept that you should all know called regression to the mean. What does that mean? That sounds kind of arcane. It means that if you take a sample of people, let's say you have a sample of people with type 2 diabetes, and you're following their progress. The main way we follow that is hemoglobin A1C. That's the lab value. And let's say that their average lab value for that is 11 when we start. That's pretty bad diabetes. If you just leave those people alone and follow them over time, that average will come down. It's called regression to the mean. The people that are the sickest tend to get a little bit better. The people that are down the bottom of that sample that are more well tend to get a little sicker. It's just happens. And so if you just observe people over time, that will confound your results. The second thing that confounds your results is this idea that learning bias, and that is something I want to emphasize that is very possible or a big contaminant in a lot of digital medicine interventions, because it's not just about giving you a pill. It's about use this app on your device. And once someone knows they're being studied and they've looked at the app, their behavior will change in a way that is almost indistinguishable from whether the thing is actually effective or not. And so for those reasons, we need control groups. Now, the next level is before and after studies, which is not quite as bad as observational, because what you do is you take a population and you measure something about them for, I don't know, 3 or 4 months or 6 weeks or whatever the right time frame is. And then you give them the intervention and measure again. Again, why is that not such a good study design? Well, because of the two things, the regression of the mean and the bias that creep in from learning about the intervention. We see that a lot. A lot of companies will do that. It's quick, it's cheap compared to a randomized controlled trial further down the list. It's not ideal. And if you are the recipient of someone saying, well, we did that, we looked at a group of people, we applied our intervention, and then the group changed. The only way I would say you can really push that into maybe being acceptable is if the follow-up period where you're observing is a long time. So let's pretend your intervention was a 3-month intervention and the effect that you saw is present a year later. Maybe you can say that that is related to the intervention, maybe. All right, the next one is case control. So that means I'm able to, and in the old days, we would do this with what we call chart review. So I would take a patient, let's say a 55-year-old woman, African-American woman, we would, and maybe that person had high blood pressure, and who knows what else. Then we would find someone in a group of people who had all those characteristics as well. We give one of them the medicine. The other one is just a chart. It's not a person we enroll in the study, but we know that person exists, and we can follow their progress by looking at their medical record over time. That's called a case control design. It's not a bad design these days. The reason is because with electronic records, we can get large samples and pretty fine matching. And indeed, I'm going to talk in a minute about digital twins as a concept for case control studies that really is starting to really blossom. And I'll draw your attention to that in a moment. So file away this notion, case control. The reason I bring it up is because it is more expedient than doing a randomized control design. And if we do it with a very fine matching, sometimes the sample, let's say your intervention sample is 300 people, sometimes you're going to match with 3,000 people to really overemphasize the potential value of your intervention. So small interventions, but a large control group can help counter the effects of not randomizing. And then single blind trials, which in our case is most of what you'll see that people are really doing fine evidence in digital medicine. That means that you as a study person know that person X got the mobile app, person Y as a control group did not. But so it's only single blinded. You know that they don't. Double blind refers to when, like for instance, again, getting back to that example of a cholesterol medicine and a sugar pill, they're two bottles of orange pills. I, as the investigator, have no idea which is which, and neither does the person who's receiving the medicine. That's the tightest design. It's almost impossible for digital medicine interventions to get that. So as I promised, I want to just mention digital twins. Very exciting, and this is an article that we just published. This is one of those plain old English editorials. So again, I invite you to look at it if you're curious about digital twins. It maps back to a paper in the journal that is a little more complex and a little more jargony, but the editorial, I think, will be good reading for anyone. And again, it's probably a 10-minute read, not a big sweat. This is going to be a really important part of digital medicine and research going forward. It is already to an extent. And the idea is that because of all your device data, all of the data about you that we can collect now, and it's not just wearables, it's some data that's coming off of your mobile device, some data from your electronic record, we can package that all up and create literally a digital twin for you. So you can become your own control, because I can now give you an intervention, and using the digital twin, I can predict what would have happened to you without that intervention, and you can be your own control. So that's really intriguing. That's coming down the pike. And it will get better and better as we get better and better at two things. One, collecting the data about you, and two, the artificial intelligence that goes into running those predictions that I talked about. So keep an eye on digital twin. I invite you to read the paper as well. Some common logical traps that we see, and some of this I've covered, so some of this is redundant. One, we talked about this already. Correlation is not causation. In many cases, if you do a proper study and you see correlation, you can say that this intervention is correlated with lowering of hemoglobin A1C, or this intervention is correlated with improved cognitive function, or this intervention is correlated with lower blood pressure. And it can go in the marketplace just fine that way. You're not saying that it caused it, but if you use that intervention, these things happen. And that is a perfectly reasonable level of evidence to be able to state. You just can't say that one caused the other. It gets very, very dicey. Digital health interventions change subjects in multiple ways. I alluded to this already because there's a learning effect. There's a challenge. Now, one of the things that happens in clinical research all the time is that you have study coordinators reminding subjects to participate, because once again, you enroll someone, that costs money. Dropouts is a big problem. You don't want people to drop out, so you call them, you cajole them. That's not like the real world. And so much of digital medicine interventions are about people's self-motivation to use an intervention. You just have to be aware that that could creep in to your results and falsely inflate, perhaps, your effect at all. The last thing on the slide, and bear with me, I'm going to try to make it quick and painless, because this is sort of something that people look at, and I think they all have PTSD from their early science days in school. but it's important for you to understand the null hypothesis and type 1 and 2 errors. So here we go. I'm going to, again, try to do it very, very simply. The null hypothesis says if I have two groups of things, they are no different. Every science experiment starts out with that presumption. I have a group of people who are using a mobile app with high blood pressure. I have another group of people matched very carefully for age, demographic, ethnicity, etc., with the same disease, not using the mobile app. I'm going to presume from a scientific perspective that they are no different, that the app doesn't do anything. That's how you have to design your study. And for, again, the founders out there, that's a painful thing to say, but that's how you have to design it. What are the two types of errors? The type 1 error says I gave that intervention to, I don't know, 25 people, and 20 out of 25 got better. And when I looked at the control group, maybe 10 out of 25 got better. That's your placebo effect. That's a big difference, right? Hallelujah, my stuff works. Well, not necessarily. And the reason for that is you didn't study enough people. Maybe if you studied another 200 people, that early phase positivity would wane back into the background. And that's where we get something called a sample size calculation. Statisticians know how to do it. If you're running trials, you should at least do it. You may decide to cut corners because maybe it's too expensive, but at least know what you're dealing with. And again, it's a straightforward calculation. Anyone can do it who has a little bit of knowledge of statistics. The second type, the type 2 error, is even more vexing, I think, for people, because what that says is if you have that same scenario that I mentioned, let's say 25 people in each group, and both groups have about 10 people that have an effect. So it looks like there's no effect at all. Again, you might be making an error. You might be cutting your study off too soon for the same reason. You need to study more people for that average effect to show itself. That's why sample size calculation is important. So you can either have false positives or false negatives, and you start out with this notion that the two groups are the same, and you see if you can refute that null hypothesis in your study. All right, that's enough science probably for anyone here. So think about where you are on your evidence journey. There's keen observation. Now, I was talking earlier about observational studies. I want to emphasize again, there's no knock on observational studies. You just can't overpromise based on them. What they do, and this is like let's think Charles Darwin, right? Went out, looked at all these different species and came back and had a bunch of hypotheses about why that might be. So let's say I'm looking at, I don't know, 25 people that use my mobile app for diabetes, and they start to get better. My hypothesis is that that app correlates with them getting better. Now I can go and study it in a meaningful way. Now, you might say, well, it's expensive to do a big trial, so maybe we should try it in a small sample first. No problem with that. 25 people, 25 controls that are equally the same, and try it and see what you get. Again, that doesn't mean your job's done, but if it points in the right direction, then maybe you do the bigger trial, the definitive trial, which has got the sample size calculation. It's got all the right best we can tools to make the groups the same, and you see. And then the final test, which is the hardest one, I think, for all of us, is what happens in the real world, because we have all seen examples of interventions, and particularly in digital medicine, where it worked in the laboratory or it worked in a clinical trial setting, and you get it out into the real world, and it's not as impressive as we might have thought. Remember, people have to be self-motivated. There are bunches of reasons that people may or may not use something when they're not in a clinical trial setting, but you have to obviously get it in the marketplace and see. You can't really, in my opinion, shouldn't put something in the marketplace that doesn't have validation. But validation is necessary, not sufficient for that big conclusion that's, yes, this really does work, and it works across large samples, and it works across people who are in the real world. So that's kind of the journey for evidence. I think that's worth paying attention to. Now I'm going to finish up, and what I'm going to do as I finish up is talk about 3 or 4 papers or scenarios. One of them has to do with some reporting in the lay press to emphasize in these various stories the power of how evidence can help us solve or deal with a challenge, an issue in the industry. And at least in the US these days, there are plenty of opportunities for us to challenge. With telehealth having gone through 2 years of growth, people are now being very cautious. They want to scrutinize it. And these questions keep coming up. So let's talk about them. Just trying to move my slide here. There we go. Sorry about that. All right. So here's an example. It comes up all the time. People will say, well, I don't know if telemedicine is of the same quality diagnostic. Are you sure? You're not seeing the person. I'm sure doctors have said this to you, right? Well, I really feel like I've got to be in person. How do we solve this? Well, I will tell you parenthetically that it's been solved many times. I mean, I got my start in my career in 1992, asking this question with dermatology images. I'm a dermatologist by training, so we proved it then. Others have proved it. This one is recent. And it's from, I believe, the Mayo Clinic, if I'm not mistaken. And it's just showing that during the pandemic, if you looked at the video calls and then brought some people in to the office and studied the two, that the correlation between the diagnoses from the video calls and the in-person was quite high. So does this put it to bed? I wish I could say it did, because again, people are going to come back with their biases and their emotions and say no. But it's another, if I can use the term, nail in the coffin of the concept that somehow telehealth is inferior to in-person care. All right, here's a favorite for now. Again, I don't know what it's like around the world. I know this is a very global audience, but in the US, health plans, payers, people who pay us to provide care are literally wringing their hands over this question. Is telehealth additive or substitutive? Is it more likely that I, for instance, as a dermatologist, will see an image from a patient I'm doing this afternoon? I'm on morning time where I am. This afternoon, I'm doing telehealth cases all afternoon. And will I see patients and say, you're right, yeah, you need to come in the office, and then somehow bill twice for that work? That's the concept of additive versus substitutive. And this wonderful, and this is from our journal, so yay for us, this wonderful paper showed that if you, with the impact of expanded telehealth availability in primary care utilization over the time of the pandemic, did not lead to excessive utilization of services, showing that it is more likely that telemedicine is substitutive rather than additive. So nice bit of research that helps us solve that problem. We're, of course, going to be putting this paper in front of all of our payer friends and see how they react to it. There's other, by the way, something also recently published in the JAMA that has the same conclusion. This one is particularly hard for me because I don't want to come across as cavalier, and I don't want to come across as defending some questionable practices from a corporate perspective. But in the US anyway, there's been a lot of press for the last, I don't know, 6 months at least around telemental health, particularly for attention deficit hyperactivity disorder. And there's 2 companies that have really been in the spotlight. One is called Cerebral, the other one is called Done. And the press has gone after them for their practices. Now, what I'd like to do is substitute or break apart, if we can, their marketing strategies from their care delivery. In the lay press, that's been all jumbled together. And I'm going to talk about Cerebral for a minute, but they did a heavy marketing presence on TikTok, trying to target adolescents, and maybe convince them that they need these medicines, these stimulants for ADHD. I would say that probably crosses a line. Again, I'm trying not to be judgmental, but I don't think anyone who looked at that, including the current leadership of the company, because the company leadership has changed, thought that was a good idea. That is in contradistinction to the idea that using a video call to prescribe a medicine is somehow poor practice. And so you can see this headline from the Wall Street Journal. This came out about a month ago. This poor gentleman indeed started out with Adderall for perceived ADHD. Yes, he got his first prescription based on a telehealth visit. And then later he got sick, and I believe he took his own life. So of course, there's a lot of drama in the press. And again, the poor man, I don't mean to trivialize his situation at all, but I got annoyed with this because it kept saying with only a video call. And again, I think it's a little bit like the fever tree for me. Just because a video call was involved, does that mean that the care was not good? Well, let's look at some evidence around that. So here's one from, 2005, recent paper from colleagues that show that telepsychiatry can replace in-person psychiatric assessments. This is a meta-analysis. Some view this, and I didn't have a chance to really talk a lot about what a meta-analysis is, but it's a compilation of lots of papers in one place and pretty high form of evidence. And they showed in this particular paper that indeed a video call is just fine for telepsychiatry. What a surprise. It's the same evaluation we do with people in the office. But so anyway, that's out there. That's out there. Even better, in my opinion, is this one, which came out recently in JAMA Psychiatry, because what this showed was that during the pandemic, the extended access provided by telepsychiatry was correlated with less overdoses from opiate use disorder and substance use disorder, fewer overdoses overall. That seems like a good thing to me. So again, and then there was a piece in the New York Times following the one in the Wall Street Journal. They weren't related, but the one in the Times was a long magazine story, again, about a young lady who got on stimulants, who had a bad outcome. What I thought was interesting about their piece was that all of her care was in the office care. There was not a mention of telehealth in the whole piece. So it's an example of let's not throw the baby out with the bathwater. I know reporters like to create controversy. They like to get headline grabs. They like to get eyeballs. That's their business. But I would just suggest to you that read these things thoughtfully, try to go back and pick out the evidence. That's the whole point of this talk, is why the evidence is important. And I think those examples help us sort that out. All right, so I'm wrapping up, and then we'll have some Q&A time. Evidence gathering takes time, costs money, and requires open-mindedness and patience. Those are all challenges for the entrepreneurial side of the business. I know that, but I urge you to think through the consequences of hasty, haphazard evidence gathering for your product. Most other ways of looking at the world are fraught with bias. Science is not perfect. I'm not saying it is, but it's probably the best we've got for trying to be as close to the truth as possible. And of course, I conclude by saying industry and academia should do more collaboratively to bring these two worlds together. Those of us in the science world have a role to play too. And that's why I mentioned, for instance, the digital twins, the case control studies, the use of electronic records as ways to speed up the process. But in all, I thank you very much for your time. These are my contact information. I'm going to leave that up as we take questions. And again, I thank you very much for your attention. Thank you.
Joe, thank you so much. So insightful. We've got a range of questions already, some of which might be quite challenging, I think. But let's start with one of the first ones, which is, how should a digital health business choose the right study design?
Well, So it depends on what intervention you have. It also depends on your budget. When you got your VC funding, did you say the tranche of this funding is going to go for validation? Is it early phase validation, which shows, for instance, that the thing you're studying just doesn't harm patients? Remember, in the US, the FDA is mostly interested in that. That's a different question than does it actually have an effect? So they're all nuances. I think hire a statistical consultant to help you, hire someone who understands study design to help you. And that's really, sorry, I had to look out the window here for a minute. That's really the best way to go. There's no kind of simple uniform answer to that question.
Yeah, which is why I said I think it was going to be challenging. But interestingly, do you think that for, let's say, well-funded startups, you were making the point that actually when they're trying to raise money, that they need to provide a budget in their budget for proper studies and costs? I guess quite a few people who are listening in might not have perhaps an idea of what sort of scale of costs. Are you able to sort of give an idea between X and Y, or is that too difficult because of the types of studies?
Well, it is a wide range, but I think what we often see is it gets compared to something like market research. Like, well, if you have a tech intervention, let's say it's a variation on, who knows, on maybe on a social network, new social network. You're going to do some A/B testing. You might get some focus groups together, you know, things like that. And of course, all these tech companies are constantly doing research, I put that in air quotes, to find out what's sticky, what brings people back, et cetera. So the kind of thing that you're going to do in healthcare is often compared to that mindset. So much of we're digital medicine, we're a crossover between tech and healthcare. So much of the people that are funding a lot of these efforts have that tech mindset. So they're going to be thinking, why not just do some focus groups? Why not? And the budgets for those can be, I don't know, $50,000 to do market research, right? It depends on the scale. Clinical trials are proper clinical trials. If you figure in the cost of your intervention, the cost of developing, the cost of staff for the study, and the cost of enrollment, and then doing the paper, I'm going to say anywhere between, and this is US dollars, but $125,000 to $250,000. Rough estimates, could be less.
What sort of organizations do you typically see people going to?
Yeah, I mean, again, most startups these days, well, generalizations, but a lot of them are actually born of a clinician who was working in the clinic and observed something, turned that into something else, maybe prototype something. And if they're bright, usually they're not always, but usually they're more often better at being clinicians and being business people. So they bring in a CEO, they bring in a management team that gets some funding, but they stay involved as either chief medical officer or chief science officer. And hopefully those people have enough background. I can think of a couple of startups that I'm advising where they know kind of how to run a clinical trial. And if they don't, then their network will have people in it. That's my usual path that I see working.
And I suspect then that, picking up that point, that non-executive director appointments with that type of expertise or clinical experts, that's where that type of expertise can be brought to bear for many of these entrepreneurial businesses.
Yeah, for some reason, you know, sometimes an important innovation comes from, remember, as I said, it's a mixture of tech and healthcare. Sometimes it comes from the tech side. Then I would just say early on, recruit someone who has this skill set to help you.
Yeah. And can we just talk a little bit about the quality of evidence, in the sense that when is evidence good enough? And I was thinking that if innovation achieves a 51% improvement, Is that good enough, assuming that the 49% of patients who might have had the innovation aren't harmed?
Yeah, I think it is. I think it's interesting, and you and I talked a little bit about this yesterday when you posed this question to me yesterday as well. I don't think of it in those terms. I think of it, if there is an effect, and it's a statistically meaningful effect, which could be 51% of a population, but that would have to be significantly different than the response in the control group, right? So if 51% of the people that used the intervention had a positive effect, the control group couldn't have 50. It's not significantly different. It'd have to be, unless it was an enormous sample, right? It'd have to be smaller than that. So it's really, then you back and say, well, I think what you look at that and say, well, what's different about the 49 that they didn't respond to the intervention, and maybe we need to tweak it to make it more powerful, but it still could be effective. 50% of any given sample of disease is a big sample.
Yeah. So we've got another question around randomized clinical trials, and saying that if that's the gold standard, which I think it's often referred to in terms of evidence, and if it's taking 17 years on average, 16 years for it to translate into regular practice in healthcare, what's the point in sort of going through some of these trials to create the evidence when it's taking 16 to 17 years, and many of these businesses will not be able to survive for anything like that length of time? What's your perspective on that?
No, it's a great question. So I think we're conflating a couple of things. The 16 to 17 years quote is about the journey of an intervention into widespread use. That doesn't mean that it took 16 years to do a clinical study. Doing a clinical study is one step in that stairway. It's not, one of the ones I love to talk about is Linnaeus and the stethoscope. That took 20 years to get into practice, not because it wasn't proven quickly, but because people resisted it. So there are different reasons things take time. But the clinical research does take time. It's faster. It's not faster. It's slower than a focus group. It's slower than A/B testing on your website. That's true. But if you get the right context and the right people helping you with your trial, you can do it in 6 months, maybe a year. Again, it depends on how hard it is to recruit. The other thing I'll just again emphasize here is this idea of case control and or digital twin. That can really speed things up, and it's almost as good as a randomized controlled trial.
So that's your vision for the future, that actually the digital twin could become the really significant thing for digital health innovations. Yes. Okay, Joe. So I think just looking at wrapping up now, and if you had one tip for those people who were submitting papers to your journal, what would that be?
Well, I will just reiterate something I said in the very beginning, which is it's those 4 criteria. And every researcher, your research is like your babies, your children. You look at it and it takes time and it's hard, and you're really excited about any breakthrough. But is it digital medicine? That's pretty easy. If you're using a digital medicine tool and you're doing something in virology, you're probably better off in a virology journal. Is it clinically relevant? That's, again, pretty easy. If it's a high degree of engineering, showing that some novel thing that you put a sensor in, maybe a new wearable, and it measures steps a little bit better, we probably would suggest you put that in an engineering journal. Is it novel? And that's the hardest one. But if my associate editor will write back to me and say, yeah, this particular group published 3 papers last year on the same topic, we look at stuff like that, right? So, or I remember someone said in their cover letter, this data, this paper is from the second use of this data. Well, that's a clue to me that that's not probably the novel paper. And then the science of quality of the science. So again, you have to look yourself in the mirror and say, did I do a good job? Is this methodologically sound? And, send it to us anyway, but those are some of the reasons you might get it back.
Well, That's great advice. And I know that given my limited science background, the ability to talk in the way that you have in simple English, to use your phrase, and for me to understand so much of what you've said, I am very grateful, and I'm sure that a lot of people who've been watching and listening to you will have learned a lot. So thank you very much indeed.
Thank you for inviting me.
You're very welcome. Cheers, Joe. Thank you.
Wow.